I'm excited to introduce our next speaker. Dr. Christine Bowen is a doctor of naturopathic medicine and a graduate of Bastyr University here in Kenmore, Washington, not far from here. She holds a board fellowship in naturopathic gastroenterology, which is pretty rare. There's only 11 practitioners in the country that specialize in that very deep specialty. In the world, actually. Yes, thanks for correcting. 1 of 11 in the world. She specializes in restoring digestive function through nutrition and holistic approaches at her private practice called Bothell Natural Health. She has had the pleasure of teaching patients and practitioners about the specific carbohydrate diet for many years. She believes that nutrition should be a first-line therapy whenever possible, and that supplements, medications, and digestive allergy testing should be considered only after nutrition has been properly addressed. She's a past guest speaker at SCDROCKS, and you can see her previous videos on our website. So be sure to check that out as well. And lastly, we're lucky to call her, again, a hometown favorite, as she's been a Northwest native since 2005. So with that, welcome. 1979. Oh my gosh. Dr. Bowen, welcome to the stage.
Hello. Thank you all for your time and attention. I'm so glad to be here in community with all of you. And if you can't hear me or something, just holler out, speak up, or lean into the microphone. Good. So basically, I wanted to talk about IBD-related conditions and considerations today because I feel like folks who come to me end up having a lot of these other things going on, and everything is blamed on IBD without the consideration of all of the other things that could possibly going on with your health. So who am I? As Allie gave me a wonderful introduction there, I'm a naturopathic doctor, board fellowship in naturopathic gastroenterology. That's new as of last year, new board fellowship. And then I've been a patient, and I also am a practitioner. So I know what it's like to be on both sides of that relationship. And I know in my heart of hearts, and because the proof exists in working with people using nutrition to help them, I know that nutrition is a valid therapy. I don't need a medical provider to agree with me because I already know this to be true. This is my family. Family is everything. Community is everything to me. And then our recent additions to our family, those little kittens up there in the corner, that's just last week. So this is what's happening at home in my house. And then this is my niece with the cute little wings. So what is a naturopathic doctor? Have all of you heard of a naturopathic doctor? Raise your hand if you've heard of a naturopathic doctor. And then if you have not heard of a naturopathic doctor, show of hands, a few folks, yeah. So who are we? What do we do? Why are we different? And so an ND is typically what our initials are, but then also an MD is what we are in some states. Like in Arizona, we're a naturopathic medical doctor. So a lot of our basic training is the same as medical doctors, but then we spend years focused on learning nutrition, learning herbal therapies, herbal medicine, even like counseling is something that's embedded in the education that we receive. We also think differently in general. I'd say as I'm talking to people, I definitely identify with embracing the gray area and exploring the gray areas of medicine instead of just saying, well, it's absolutely this or it's absolutely that. What about the whole unexplored territory or the conditions that look like they're a little bit of this and a little bit of that? So the gray area is definitely something that I explore, and then we're always looking for the root cause of what is happening with people's health and why it's out of balance. So instead of just treating symptoms, yes, you can treat symptoms because if you're miserable, you want some symptom treatment, but then really to have somebody focus on finding and then addressing the true root cause of what's happening with somebody's health imbalance. That is who we are. And then we spend a lot of time with our patients. Typically, my visits are anywhere between 45 minutes and about 90 minutes per session. So I feel like if you're really working with somebody on nutrition, you're really trying to figure out health history, all of the details, it's hard to extract that in 5 to 10 minutes, right? You like rush to try to tell them your life story in like 10 minutes after you've been waiting for an hour. So that is not necessarily what it looks like when you're seeing naturopathic doctors. And then we are trained in diet and lifestyle guidance. And then me, a little bit more than other colleagues, I focus on nutrition in about 80% of my practice. And then healthcare partnerships are what I consider my relationships with my patients to be. So this is a room where we can have open discourse back and forth. This is not a room where I say, you must do this or else you must leave my practice. That is not going to happen. So healthcare partnerships are something that I really love to foster. And then about this talk, so why did I pick this particular subject to speak on? And so it's because after almost 20 years in practice, there are some things that I see over and over again that are not necessarily being addressed by the time people are coming to my practice. And so I really love to educate people, and I feel like that is how we empower ourselves to move forward with confidence and being able to advocate for ourselves, is having some of that education to be able to empower ourselves. So oftentimes when I see people coming in frustrated, they've seen 20 other providers, these are some of the things that I'm finding or starting to address. And then I really hope that what you take away from this talk is that you're more than an IBD diagnosis, right? So if you have other symptoms going on and you're asking for a provider or a system to address those other things, and they keep on coming back to your IBD, it's because once they see that diagnosis, it's the same if somebody has like a history of substance use disorder, that anytime they go to the hospital, they're always going to be judged by this history of substance use disorder. And I feel like it's the same when people have this one diagnosis, that the people who see them are only seeing that diagnosis and they're not able to see outside of it. So I hope that you have exceptions to this experience, but I find that this is typically what is happening. So I really want to raise awareness of these conditions and also their connection with IBD as well. So what we're going to talk about today, a little overview of the GI tract. We're going to talk a bit about celiac disease, autoimmune diseases of the liver and pancreas. And a lot of this is autoimmune disease adjacent, or some of the things that can happen when folks also have autoimmune disorders. Sjogren's syndrome is something we'll talk about. Talk a little bit about immunoglobulin deficiencies, and so this is basically an immune system deficiency. And then IBD, extraintestinal manifestations, bile acid malabsorption, which can be another cause of urgent, frequent liquid stool. And then also exocrine pancreatic insufficiency and short bowel syndrome. So those may all seem like just a bunch of medical terms, but hopefully we'll be able to parse them apart and be able to explain why you should consider each of these and know at least a little bit about each of these conditions. So you have to pardon my picture on the left there because it's been much copied and transferred from, I can't find a substitute for it, but basically looking at the picture on the left, that's telling us what's happening at each stage of digestion in human terms. This is not the most scientific exploration of all of the things that are happening during digestion, but it at least will walk you through from the mouth. We have digestive enzymes in our saliva. We also have the mechanical chewing to break our food down. We swallow it, and then we end up having more chemical digestion in the stomach, secreting things like hydrochloric acid, moving down into the small intestine. The liver and the pancreas are donating digestive enzymes there to the small intestine to further help break the food down. So you have all of these stages where things are happening that are influencing how we're digesting our food. And at any of those stages, something could go wrong that then could increase our risk of having digestive symptoms or even be caused by something like an autoimmune disease. So kind of knowing what's happening in each of these areas, and then looking at the slide on the left that basically that's talking more about what's absorbed at each stage. And so when we look at the stomach, then you do have a few things that are absorbed in the stomach. You have quite a few nutrients. So the vast majority of our absorption of nutrients from food is happening in the small intestine. So if somebody has their small intestine removed surgically, then what do we need to replace when it comes to nutrition? And then how do we replace it? So these are things that might be considerations. So if you're looking at this and you're like, oh yeah, I have my terminal ileum removed. Well, that means that these are the sort of things that I need to be working on. But then also, this is where something is reabsorbed. So in the terminal ileum, so the slide on the left, down at the bottom, bile salts and acids are reabsorbed in the terminal ileum. So they're released by the liver, and then they help with breaking down foods and fats. But then here, they're reabsorbed in the terminal ileum. So if you're missing that piece, then you're gonna end up with bile acids in your colon, which irritates your colon, and then will make you have urgent, frequent diarrhea. So also water being reabsorbed in the colon is how then we're compacting or making formed stools. So if somebody has a colectomy, the likelihood of having a formed stool goes down tremendously because you're not able to reabsorb that water. So it's definitely just like thinking of these different things at different stages and setting the stage for saying, now we're going to discuss when things go awry in some of these different locations or with these different organ systems. Is everybody with me so far? Okay. Celiac disease. So this is something that I feel like is on the verge of being a public health crisis, if it isn't actually a public health crisis, because more than 80% of people with celiac disease are undiagnosed or misdiagnosed. And that we used to think that it was 2% of the population that had celiac disease, but there were some mass screenings, and I just found out today that Dr. Faisano was part of the team in Italy that it did a mass screening of children to see what the incidence of celiac disease actually was. And it wasn't 2%, it was 4%. It was double the amount that they actually thought that it was for many years. So this is significant. So 1 in 133 people is what we were saying before, and that's, you know, we thought it was 1% and now it's 2%. But when I was talking to him earlier, we were talking about it doubling. So first-degree relatives, how many people have relatives with celiac disease? Yeah. So we used to think that it was 1 in 4 family members, close family members, or what we call first-degree family members that would also have celiac disease, and now we realize that it's 50%. It's 2 in 4. So when you're thinking, well, it's only 1 in 4, and then you're like, that's not me. And then you're like, whoa, okay, let's take another look at that. So it's definitely double, bare minimum double what we thought it was. And so it's significant. The average amount of time that it takes somebody to get diagnosed with celiac disease is 6 to 10 years. Sounds like also for maybe IBD, right? That it could take that long. And then the global incidence of celiac is increasing. They do think that maybe it's environmental factors going on that are putting more strain on people's systems. So maybe they had the genetic predisposition to have celiac disease, but then with our environmental factors getting worse, then is that triggering more celiac disease onset? And then people from Northern European heritage, especially like Ireland and Italy, have a higher risk. And then remembering that celiac disease is a true allergy to gluten. This is not gluten sensitivity, this is not gluten intolerance, this is a true allergy to gluten down to the molecule. So if you're being a nice friend and you have a person over with celiac disease and you think that you can cook for them in your kitchen that has had gluten in it, it's not safe for that person. So unless somebody has taken all of the measures to ensure that there's no cross-contamination, then celiac disease is not really being adequately treated. So if you know somebody with celiac disease and they're like, I eat gluten every now and then, it's like that is untreated celiac disease or not adequately treated, and then it keeps the autoimmunity going. So you see this little picture up in the corner, that's basically the damage that happens to those little fingers in the small intestine. So normally they look like little fingers, those little villi, but this is what happens. They get flattened, they get cut off by an autoimmune process. So it's very intense what happens with celiac disease, and there are a lot of secondary consequences, including things like higher risk of gastrointestinal cancers. And then for non-celiac gluten sensitivity, then 6% of Americans are estimated to have that. So these are pretty high rates. And so that the only treatment for celiac disease currently is a strict gluten-free diet down to the molecule. The symptoms for celiac disease, there's a lot of overlap with inflammatory bowel disease. And so adult symptoms can be things like fatty, greasy, or pale stool. And digestive symptoms might not be present for people with celiac disease. They might actually only have fatigue or mood changes that kind of came on out of the blue. So fatigue and weakness is common. Oral symptoms, especially things like ulcers. So oral ulcers can happen because of a lot of things, but when I see oral ulcers, I'm always thinking about celiac disease rule out. Other symptoms are associated with just about any other autoimmune condition. So when you have an autoimmune condition, it's like the stage is set for your body to develop more autoimmune conditions. Once an autoimmune condition has pushed its way through, others might be short to follow, or at least try to, take hold. But basically with celiac disease, I'll see people with 5 different autoimmune conditions, because until the celiac is addressed, then your immune system is so compromised that you're going to keep on kind of collecting autoimmune conditions until that's really addressed. So reduced fertility is something that we don't normally blame on celiac disease, but celiac can cause a lot of malabsorption of nutrients, which means then a lot of nutrient deficiencies, which then means you don't necessarily have the building blocks for all of the hormones or for normal body processes. So it can be, you can have reduced fertility in men or women with this. Also things like irregular menstrual cycle. I've seen UTIs as well for people who have chronic UTIs, for people who have celiac disease. It just creates a whole corruption of the immune system that then can affect people globally. So it definitely tied to mood changes like anxiety and depression. And I asked Dr. Fasano the question, do you think that celiac disease is a mental health crisis today? And he said yes, because 80% of people with celiac disease have mood disorder. That's secondary to the celiac disease, not just something that can happen chemically or environmentally for people. But this is secondary to nutrient deficiencies. And so are we screening for celiac in folks who are presenting with mental health concerns? Not often that I can see. So also for children, we might see things like failure to thrive, which means that, that child is not growing or hitting their milestones that they're supposed to, weight, height, any of the other milestones that we're expecting. So failure to thrive can be just a very underweight child that's not hitting those milestones, or it could be life-threatening. Stools can be soft, bulky, or even clay-colored. When you see clay-colored stool, you should be thinking, what's going on with this person's liver or my liver? If you see gray stool or tan stool that is not brown, brown of some hue, then you should be thinking, what's going on with my liver? So like the color of these chairs, putty-colored. So if people have stool like that, there's something going on with the liver. That's like 100%. So in conditions like celiac disease, there oftentimes are other organs that are being impacted, not just the small intestine. So diarrhea, I love the term offensive diarrhea. We call it malodorous as well. So many names, so many words to say that this stool really stinks. But offensive, and then also kids who have a low-grade fever, chronic low-grade fever, no clear cause about why, definitely screening for celiac disease. Some digestive symptoms definitely, could be part of it, but then things like being underweight, generalized weakness, abdominal distension, so it cut off that word. I am probably aging myself, but we used to see the commercials of folks from Ethiopia when they were having, absolute terrible, like a hunger crisis. And you'd see these kids that were super, super underweight, but they have these big old bellies. And so what's going on with that big old belly? That's called protein malnutrition. And so when you don't have enough protein, then the fluid leaks out of your blood vessels. And so then it can collect. So when you don't have enough protein to keep that fluid inside of the vessels, then you have it leaking out and creating symptoms like that. So those are kid symptoms versus adult symptoms. And then if you don't treat celiac disease, then it can definitely, you can collect autoimmune diseases. We already talked about that. You can have plenty of nutrient deficiencies, including anemia. Sometimes they're like, I don't know why, but my ferritin is 3, which means that you have really, really low iron. So something like celiac could be co-occurring with IBD, which is confusing because then you're like, my IBD is in remission, or it's very low inflammation, but then my iron is so low. Is it that you're still getting trace exposure to gluten? Could this be a reason why your iron is not coming up? So any of those nutrient deficiencies, and then calcium being something that is malabsorbed, then can lead to osteopenia, osteoporosis, bone fractures, and then other things that can happen. So lactose intolerance. Oftentimes when I see lactose intolerance, I see it when people have had a gut infection and their gut just never recovered its function after that. But then also things like celiac disease, where if you lose those little fingers, you lose some of the enzymes that are on the tips of those fingers that help you break your foods down. And so if you don't have lactase enzymes, then you're gonna have a heck of a time digesting lactose. So I oftentimes will see that lactose intolerance may be secondary to something else. And then if those little fingers are damaged, then you're not sweeping food or organisms through your gut the right way, and you can end up with organism overgrowth in your small intestine, instead of those organisms being deposited into your large intestine where we expect to find more of them. So definitely, again, the risk of cancer and then fatigue being significant. So how do we get a good diagnosis? A lot of people self-select for going off of gluten because it makes them feel bad, so they go off of it. And when we have people go off of gluten, we've lost our chance to be able to do this celiac panel while somebody is having exposure. And so if you're not having active exposure right now, then this panel becomes less reliable. So a lot of people don't want to go back on gluten either because it will hurt them. So when we went off of it because it hurt me, I don't want to go back on it because it hurts me. But oftentimes that's the only way that your doctor will say, okay, we can do this panel, but you have to go back on gluten for a month before we do this panel, or you have to go back on gluten before we do an endoscopy with small intestine biopsies. Well, there are other ways to test for celiac disease. Yes, even if somebody is off of gluten, I still will do this panel, because if you're getting trace exposure, then it still might have some markers on it that show up positive. There's this marker called IgA, and we'll talk a little bit more about it later, but immunoglobulin A. When the small intestine is destroyed like this, or harmed like this, then IgA goes down, because like those enzymes that are at the tip of the fingers, this immune system marker is also on that surface lining of the gut. So we need enough of this IgA to get a good result of this panel. But if somebody has celiac disease, they're likely to have deficiencies in this marker that we're testing for. So it's kind of a setup. If somebody has celiac disease and they're not making enough of this marker, and they just say, well, your test is negative, it's like, but that marker is low, which can mean celiac disease. So low IgA can be due to celiac disease. So if any of your doctors have ever tested your immune system markers and they said, you have low IgA, but we don't know why, then celiac disease should be something that you're thinking about exploring. There are other things like low albumin that also can be low in IBD. And so albumin is basically one of the proteins. And so if we're not absorbing proteins, we're not going to have enough of this albumin. So also liver function tests being elevated. So when we think of liver function tests, they don't necessarily just test for the liver. They're also testing for small intestine muscle. They're testing for heart muscle, other types of muscle in our body. It's not just about the liver. So if you see this elevated liver test and they say that's normal for you, I don't accept elevated liver tests being normal for anybody that I've found yet. So that's something that I would love for people to follow up on. And then you don't have to reintroduce gluten to get your celiac genes tested, but you have to have a doctor who's willing to order them, or you can find sites that do self-order, self-pay for this. The 23andMe test, I don't think it gives all the details that you need, but it's better than nothing. So if you see, oh yeah, I have a very high risk of celiac disease on my 23andMe, it might be these markers that are showing up positive. And then there's another marker called HLA-DQ7, which is less likely to be positive for people who have celiac disease. So the genes are set. They're going to be the same until the end of time, right? So if you keep on retesting them, they're not going to change. But if you test them, you get this result that's at least a risk ratio of, like, in your lifetime, how likely is it that you will develop celiac disease? And on the very low end would be like 1 in 2,000 people with this pattern of genes is going to develop celiac disease. And on the very high end, it's 1 in 7. And so if people are on that, 1 to 35 and above side, then we're highly suspecting that celiac might be part of the equation. But then we have to do a lot more talking and experimentation to figure out if we're really going to have them commit to a life of gluten-free down to the molecule, because that is not easy. You all have adapted to making some pretty tremendous dietary changes throughout the years. Gluten-free down to the molecule adds this extra element to all of that. And so I don't want to just have people experiment doing that, but if they're able to experiment by, purchasing pre-made food that they know is gluten-free for a month and then solely eating that and not getting exposure, then that means that you don't have to, like, clean up your whole home or make your family go gluten-free with you. It's something that you could experiment with, but you want to have at least some suspicion that celiac is going on before you go to that level of, diligence. So intestinal biopsies, sometimes people get endoscopies and they don't get small intestine biopsies at all. Sometimes they just do endoscopies without biopsies. So that opportunity is lost to get that information. The thing with the biopsies is that you only are taking biopsies from that first segment of the small intestine, but the small intestine is like 20 to 25 feet long. So that we expect to get answers only in that first portion is I wouldn't say it's unlikely, but it's not seeing the whole picture, really. So that first portion of the small intestine is where they do the biopsies. If you have if you have an endoscopy coming up, you can ask, are you going to do 4 to 6 samples of my small intestine to test for celiac disease? Because they might, as a matter of course, just do 2 samples or no samples. And so at least that would be a chance for you to take advantage of that endoscopy, because we don't want to repeat an endoscopy, if we don't have to, right? And then I see a lot of reactive gastropathy, which just basically means my stomach is inflamed, and we don't know why. And so I'll see that on endoscopy reports for people with celiac disease where they have negative biopsies, but then their stomach is inflamed, but they don't know why. And so celiac disease definitely can explain something like a reactive gastropathy. Okay, is everybody with me? I'm like, this is post-lunch. This is the hardest slot for sure. Okay, so we're gonna talk a little bit about autoimmune diseases of the liver. I know this is like really fun conversation, right? But basically with autoimmune diseases of the liver, there is a significant risk, especially with primary sclerosing cholangitis. 80% of people with this condition also have ulcerative colitis. And so that's why I want you to know about it. And then if somebody has a pale stool, then you're thinking, it might be liver, that's involved in this. And then kind of going down the path of, has anybody ruled out autoimmune liver diseases that could be co-occurring with my IBD? So autoimmune hepatitis, basically what happens with that is you have, with all of these, there's a genetic risk. And so this is something that Dr. Faisano also pointed out. You have a genetic risk for developing these conditions, but then you have environmental factors. And so the environmental factors can be the medications you're taking, antibiotics, toxic exposures, nutrition, any of these things, even like hormone changes. So environmental factors, infections. We know all too well that oftentimes infections can trigger autoimmunity or be part of that like final straw. So maybe you had the genetic risk for these conditions or for IBD, but then you didn't develop it until you got some of those other environmental hits. So it's going to be the same with these conditions here, that primary sclerosing cholangitis, primary biliary cholangitis, and then autoimmune hepatitis are all going to be secondary to environmental factors plus genes. So the liver, I just want to like take a minute and tell you how amazing our livers are. Does anybody know that the liver can regrow itself? Anybody? Is anybody? Yeah. So if the liver is less than 50% damaged, it can regenerate. So there's this salamander that if it loses a limb or it loses its tail, it can grow it back. Our liver has that same capacity. And so I just want to give a moment to appreciate how amazing the liver is. So it's got all of these awesome functions, including things like controlling our clotting, regulating our cholesterol. It's also involved in blood sugar balance. It produces proteins. It cleans the body of waste. It breaks down and neutralizes toxins. It also helps with organisms, keeping the organisms in check. So if any of the liver processes are breaking down, there could be serious consequences here. And so looking at how many things are dependent on ideal liver function to go correctly, then also thinking, well, if any of those things take a left turn, these are some of the things that could be impacted. All right. Yeah, so liver, normal liver, and then when the liver gets damaged, it creates a condition called fibrosis, where it becomes stiff. Has anybody eaten liver? Yeah, there are only a few of us who have admitted that we love liver, but the liver is really, it's squishy. It's meaty and squishy, and it doesn't really have like clear muscle fibers in it. And so when you have damage to your liver, then it becomes stiff. And when it's stiff, it's not functioning as well. And then if stiffness goes on or that fibrosis goes on, then it can turn into a fully damaged liver, which is cirrhosis. And then cirrhosis is when you have cartilage basically replacing healthy liver cells. So anybody who's had liver has probably noticed that there wasn't a lot of cartilage in that. And so an unhealthy liver would basically be non-functional in so many different ways, but because it's like those healthy liver cells are being replaced by cartilage. But then if you remove underlying causes to what's creating the fibrosis in the liver, especially when you hit it in that middle spot when it's just early on in fibrosis, you can completely regenerate the liver or repair or heal it, which is tremendous. So I'm like, our amazing liver. So autoimmune hepatitis is an autoimmune disease, as would be implied, and that it can cause liver damage, fibrosis, or even liver failure. And so there are two types. One typically will happen in children, and the other one will happen in adults. And then there are blood tests to test for it, and the main one is called anti-smooth muscle antibodies. And so this is something that I definitely want to test when I see that somebody has a very pale stool or some of the symptoms associated with some of these liver conditions. You also can test something called serum bile salts. So the bile salts are released by the liver into the small intestine. They're reabsorbed in the terminal ileum. And then if something's going wrong with the liver, suddenly they're kicked into the bloodstream instead of the digestive tract. So something like checking for bile salts in the bloodstream is like, you find these and you're like, what's going on with the liver? Let's go ahead and do some of the deeper testing. And then you might want to do an ultrasound as a starting place to see how the liver is looking, if it's enlarged. But then there's this test called a fibroscan that can really measure the amount of stiffness or that fibrosis in the liver. And so that's my favorite test, because sometimes I'll see a totally normal, even like an MRI that's totally normal, an ultrasound that's totally normal, but then you measure that fibrosis score and it says there's advanced fibrosis here. And so we thought it was in the liver, but everybody did an ultrasound and it looked normal, so they moved on. But then you go back and you look at something like this fibrosis score, and it really can tell you, like, we need to get to work quickly on helping to reverse what's going on with the liver here. So this condition is associated with many other autoimmune conditions, as autoimmune conditions are associated with many other autoimmune conditions. So collect them all, I think, is typically like what happens with your immune system, where it's just like, oh yeah, I have one. Let's go ahead and invite a couple of other friends over. And it's like, no, close that door, keep them out. So those are some associations. Even things like vitiligo can be associated with autoimmune hepatitis. And symptoms can be anything from fatigue to like that pale stool, yellow skin and eyes, abdominal pain, you can have joint swelling. You can even have like high blood pressure without clear cause. That can also be due to liver compromise. And then deficiencies in some different fat-soluble vitamins, because the liver is controlling fat and fat absorption, right? So vitamin A, D, E, and K all are fat-soluble vitamins. So if your liver is not functioning correctly, then this also could compromise the other fat-soluble vitamins there. Sometimes people will come in with a cholesterol panel where they're like, my cholesterol is amazing and my cardiologist loves this. And I'm like, that's great. I'm looking at it though and I'm thinking, oh, I think that this is fat malabsorption. I think you just have too low of cholesterol because you're not absorbing your fat. And so that's the bad news. I feel like I'm sometimes like, yeah, I know it looks amazing on the surface, but I think that it's low because of something else that we need to address. Hormone deficiencies. Did we know that most of our hormones are made from cholesterol? So cholesterol is like the mama hormone. And then all the other hormones are made from cholesterol. And so when we look at, this approach of like less is better for fat in our bloodstream, we're like, cholesterol should be as low as possible. It's like, well, we actually need that for some pretty vital processes to happen in our bodies. And so something like having adequate cholesterol is how you can make healthy hormones. So just thinking about that when it's like, lower is better for cholesterol, no, I wouldn't necessarily agree with that. You could have neurological changes because fats are really also, they're so important for the function of the nervous system as well. And then SIBO symptoms can happen with autoimmune hepatitis. Sometimes people think that they have SIBO or they test positive for SIBO, and then SIBO is being treated, but it's actually secondary to something like celiac disease or secondary to something like autoimmune hepatitis or endometriosis. There's so many things that SIBO can be secondary to. So we're in this era right now where we're all getting tested for and treated for SIBO. Or maybe, has anybody heard of SIBO, small intestine bacterial overgrowth? Yeah, I feel like it's made its way around, but then my question is why, right? Why is that happening? And if you took the treatments and you got 100% better, then you probably did just have SIBO, right? If you took the treatments and you got better, but you relapse right away after you're off of the treatments, then this is probably SIBO that's secondary to something else. There's a condition that can happen secondary to the liver being damaged, and it's called hepatic encephalopathy. And this basically means that when your liver's not functioning, it makes you cognitively unwell. And it's because you're being poisoned by ammonia. So when the liver's not functioning, it helps with neutralizing ammonia. And so when the liver's not functioning well, circulation changes, certain organisms overgrow, and then it creates more ammonia. So people will feel confused, they'll be disoriented, they'll be dizzy, they'll be agitated. And so this is something to think of like for somebody who's suddenly changed cognitively. And so, liver disease can happen secondary to alcohol. We definitely know that. We're talking about autoimmune disease today, but anytime the liver is compromised, it could result in these sort of symptoms. And so the treatments typically are things that are going to reduce the strain on the liver, including grain-free, lactose-free, refined sugar-free nutrition plans. Sound familiar, right? Meal spacing or intermittent fasting for insulin resistance, so that can take strain off of the liver as well. Regular vigorous activity, if you are able to do regular vigorous physical activity, that also can help the liver metabolic processes. And then if the liver is really compromised, then you might need some enzyme replacement to help put the function back. So if you're missing the ability to deposit bile on your food and break it down, then we would give you some supplemental bile. So this is, again, only after we understand what we're actually treating, right? Pancreatic enzymes might also be something that people need or will benefit from because the pancreas and the liver share a duct that dumps into the small intestine. So sometimes there's a problem with the liver that just translates to a problem with pancreas or vice versa. So either one of them could be involved, and then they're both helping us break our foods down. So if one of them's not working, then it's likely that we might need some assistance breaking our foods down better. And then things like ox bile or bear bile, those actually can help the bile flow more smoothly out of, it thins it so they can flow out of the liver more easily, but then it also helps the liver to repair itself. So we're not just supplementing an enzyme that's missing, we're actually helping to bring something on board that could help the liver repair itself. And we want to take advantage of that liver being able to regenerate itself, right? And then things like modulating the immune system. So not suppressing the immune system, not stimulating the immune system, but modulating the immune system means helping the immune system to balance itself out. And low-dose naltrexone is something that I use a decent amount of to help with immune system modulation. Things like liver herbs that can prevent inflammation or treat inflammation. They might prevent fibrosis of the liver. And then these treatments help to reduce those organisms that create the ammonia. So these are two pharmaceutical interventions. One of them is one that people use in SIBO. So sometimes people feel much better from their SIBO treatments, but it's not just because we're treating SIBO, it's because we're actually treating something that's creating a strain on the liver. So it's very interesting. And so the PSC is the one that I want you to know about more, that basically more men than women are going to get PSC, and that it's mostly associated with ulcerative colitis, in that 80% of people with PSC have ulcerative colitis. So they co-occur a lot. And then PSC is also associated with trichloroethylene exposure. So trichloroethylene is a dry cleaning chemical. So this dry cleaning chemical was too toxic for your liver to be able to clear out and created autoimmune disease in that case. So if anybody still does dry cleaning, consider something that's a little bit less toxic. There are some cleaners out there. And then the symptoms could be same. So like anything for the liver, it's like pain in the abdomen. Your liver is on your right upper side, and so pain there is not generally normal. So that's something that you want to get investigated for sure. Itchy skin, that's because the bile salts build up in our skin when they're in our bloodstream instead of in our digestive tract. Things like jaundice or that yellow skin, yellow eyes, that also is like, aha, what's happening with the liver if you see something like that? Feeling tired or weak. And then the positive autoimmune blood work is kind of non-specific, so you would have to do more workup. It just would say positive ANA, but that could mean a lot of things. So you just would have to have somebody who's doing imaging that's looking specifically at the bile ducts, looking at the liver to see if there are any problems with the ducts being dilated or damaged. And then PBC, I just want you to know, because sometimes these two conditions get confused. And with PBC, it's a much more rare condition. It's more women than men impacted, and that it also attacks the bile ducts of the liver, versus PSC, or primary sclerosing. It can affect areas outside of the liver as well. So it's kind of inside and outside of the liver, versus PBC is mainly in the liver. And PBC is associated with other autoimmune disease. This is going to be a theme, right? All right, so autoimmune pancreatitis. Has anybody ever heard of autoimmune pancreatitis? Yes, people know. Some people know. I'm sorry that you know, right? But autoimmune pancreatitis, so sometimes people with celiac disease, they have pancreatitis, and we don't know why. Well, autoimmune pancreatitis is something that can be part of a continuum of other conditions. So basically, when you have certain types of autoimmunity, autoimmune pancreatitis can be like lumped in with some of those autoimmune conditions, but it can also be its own thing, and it can create calcifications in the pancreas. What does the pancreas do? Yes, I'm like endocrine and exocrine for the win, yeah. So endocrine is blood sugar balance. Exocrine means it secretes stuff. And so when it secretes stuff, it's secreting digestive enzymes. Those digestive enzymes help us break our food down. Well, if you have pancreatitis or acute inflammation of your pancreas, it starts breaking itself down. That is very uncomfortable. Would not recommend it at all. So one of the tests that you can do for autoimmune pancreatitis is IgG4. And so this test can mean other things, but it's that and then some imaging tests normally will get you a diagnosis of autoimmune pancreatitis. You can check for markers in the bloodstream like amylase and lipase, which are the enzymes that the pancreas secretes. So you can check for those enzymes as well. So there's your pancreas, and you can see that it shares that little duct with the gallbladder, and it's all dumping into the small intestine there. So you can see how something that affects the liver might affect the pancreas or vice versa. They're so tightly intertwined. So basically, you want to do blood tests here to get the diagnosis. You also can do stool tests to see how your stool or how your body is breaking down, how your pancreas is breaking down your food. So there's this marker called pancreatic elastase. If it's low, it means that there's a low amount of pancreatic help for breaking your food down. So, and then that can be associated with a condition that we'll talk a little bit later, which means that the pancreas is not functioning correctly. What are the consequences of that? And then what do we do about it? So we'll talk about that a little bit later. But then you need imaging to see if there are calcifications or cysts or anything like that in your pancreas. And then the treatment, you need to calm or control the autoimmunity and inflammation, and then definitely need to replace the digestive enzymes. There's specific pancreatic enzymes that you can get over the counter or by prescription. And so I recommend, having your provider tell you how many of those you should take or what type. But it's something to know that if you have pancreatitis or if you have anything that has compromised your pancreas, you definitely need to replace the pancreas function. Otherwise, your food is partially digested, and then the bugs love it, and then they eat it up, and they ferment the foods, and they make you feel miserable. So they give you lots of fermentation and loose stool and all of these other symptoms that are secondary to not breaking your food down correctly. And then you might have to manage secondary conditions such as diabetes. So if your liver, or if your pancreas rather, is significantly damaged, then it means you might lose that blood sugar balance piece that it does as well. And then it might be managed similarly to these conditions that we'll talk about, and we'll just call them EPI and BAM for brevity, because they're two very long names, but we'll talk about them more a little bit later. How am I doing on time? Okay, so Sjogren's syndrome, I have a desert here because Sjogren's syndrome makes everything dry. Dry. Dry mouth, dry eyes, vaginal dryness, dry gut, dry everything. And basically, it's an autoimmune condition that attacks secreting glands. This could include things like the pancreas, the liver, salivary glands, your parotid glands. All of these things that are secreting can be attacked by your immune system. And so then you lose a lot of those normal digestive juice functions that we talked about in the beginning, right? So replacing those digestive juices is at least a piece of the picture, but then you might want to test for other conditions, other autoimmune conditions, making sure that your inflammatory markers are not elevated, and then testing your stool again. So things like testing the stool for pancreatic elastase is like, how's my pancreas functioning? Stool, muscle fibers, and fat, a random test, tells how am I absorbing and digesting fats and proteins. So just in those three tests, you can start to figure out how you're breaking foods down and if there's something missing that needs to be further investigated. So Sjogren's syndrome, I think I covered a lot of the replacing pancreatic enzymes. So immunoglobulin deficiencies. So we have 5 main immunoglobulins. So these are immune system markers that are called upon when the body is under attack. So if it's under attack, it's seeing a bacteria or virus, or it's having an allergic response, then these immune system markers will come out and help fight the fight. So if you have deficiencies in these markers, then it means you're not fighting those fights very well. So people might have chronic infections that they're just not getting over because they don't have those immune system helpers to be able to jump in there and help. So there's something called selective immunoglobulin deficiency or common variable immunodeficiency. It just means that one or more of these markers are deficient. The most common one to be deficient is IgA. And then earlier we talked about how IgA might be deficient just because of celiac disease. So is this common variable immunodeficiency always what's happening if somebody's immune system is missing one of these markers? Or is it secondary to something like celiac? And then the treatment, if you're missing these immune system markers, is to take them. So sometimes they'll give you IV treatments of these immune system markers, or there are some oral products that you can take, powders that have these immune system markers in them. So IgA protects the respiratory tract and digestive tract. No wonder it's low in celiac disease, because it's protecting the digestive tract, but if it gets destroyed along with those little fingers, it's going to be deficient. So you'll get lots of infections secondary to a low IgA. Same with IgM. So when we get things like mono, heaven forbid, or even like COVID, if you get sick, the very first one of these immune system markers on the scene is IgM. And so that's the first one to go up, it's the last one to go down. Again, if you're missing it, chronic infections happen. IgG, this one is also associated with helping our bodies fight infection, but this is the one that will stay positive years after you've had an infection. This is like the memory of that infection. And then IgE is that acute reaction. So let's say somebody has a peanut allergy, or somebody has a true dairy allergy. That's going to be an IgE reaction versus something like IgG would be more of a chronic sensitivity, or like a chronic reaction. And then extraintestinal manifestations, basically it can affect you in so many different ways, but I would say that rheumatoid arthritis is one of the most common secondary IBD extraintestinal, and extraintestinal just means outside of the intestines, right? Is it related to IBD? Is it outside of the intestines? That's what these are. So anything from like an inflammation of the eye, inflammation of the surrounding area of the lungs, those sort of oral ulcers or mouth ulcers that also could be positive with celiac disease, less pancreas function, so that also is something that can just be associated with IBD. But you better make sure it's not due to something else first, right? And then a lot of other inflammatory conditions or autoimmune conditions, blood clotting, blood vessel conditions. And so it's just like, knowing these sort of things are there. Don't worry necessarily about, I'm going to get all of these things. But if something weird happens, then it might give you a clue. Oh yeah, that's right. I remember this slide or this picture that said these different things could be secondary. So if you're in a flare, especially when you're in a flare, that's when these things are more likely to happen. And so if you're getting some weird other symptoms, don't ignore them. They still may need to be treated like they're their own condition, but it's good to know that these things exist so that you're at least aware. And with ulcerative colitis, there's the list there, and one of them is like inflammation and autoimmune disease of the spine. So ankylosing spondylitis is what that's called. And with Crohn's disease, it's mostly arthritis, but it also can cause ankylosing spondylitis and MS. So just thinking like, how are these things connected? I feel like I'm all doom and gloom, but I hope it's education, right? I'm like, I know these things are very serious, but I just want you to know. So these are the last two things that I'm going to talk about, or actually there's one small topic. Bile acid malabsorption. So remember my much loved and used slide. So basically we see how those bile acids are supposed to be reabsorbed at the terminal ileum. If you're missing the terminal ileum, or if there's irritation, if you've got frequent urgent diarrhea, then there's probably not time even to reabsorb those bile salts. If the bile salts end up in the colon, that irritates the colon evacuates. And so bile acid malabsorption, one, it means that the bile salts are leaving, so you didn't get a chance to absorb the fats the way that you should have because of that. So you might end up with greasy, sticky, frequent bowel movements that are just like, unhappy bowel movements. And so it causes rapid motility when those bile salts land in the colon. And so that urgent, frequent stool can definitely happen. So the bile salts are supposed to be reabsorbed, and if they're not, this is what happens. And so any of the conditions, IBD-related conditions where you might have urgent diarrhea, you might have bile acid malabsorption just because the transit time is so fast through your intestine, there's no time to reabsorb. So oftentimes, if you're having urgent, frequent liquid stool, you probably have bile acid malabsorption. The way that they determine whether or not you have bile acid malabsorption is by treating you for it and seeing how you do. So the treatments for it are typically an old school cholesterol medicine, which basically binds the stool and it will bind those bile salts so that then the bowel movement frequency and liquidity, how liquid it is, will reduce. So these are causes of bile acid malabsorption, but surgery that removes any of that portion is definitely a cause. People who have their gallbladder out and suddenly their bowel movements have never been the same afterwards, that's normally because suddenly they got bile acid malabsorption. So many other things that can cause bile acid malabsorption. And so then typically people are given these treatments. The holistic treatment version of it is sunflower lecithin. And then they might reduce fat in their diet and see if that calms down the urgency or frequency of the bowel movements. That also could be a way to test. The fecal fat test, they give you, has anybody done a 72-hour fecal fat test? If so, I'm so sorry. They give you a paint bucket and they send you home and tell you to poop in that for 3 days. And I'm just like, the logistics don't even make sense to me, So we have a random test that I prefer to do instead of 72 hours. If somebody hands you that paint bucket, ask for a random test instead, because this is near to impossible to try to get people to do. And I wouldn't ask anybody anything that I won't do myself, and I don't think I'd do that. I don't think I would. And so the diagnosis is normally made by your response to your treatment. That's it. So EPI, so the pancreas, so in pancreatitis or other conditions that autoimmune pancreatitis, the pancreas has been damaged, then you don't have those enzymes breaking your foods down. The foods are partially broken down. They're eaten by the bugs. Fermentation ensues, and then you have liquid diarrhea. So basically, when you don't have the digestive enzyme function, then this is the result. So fatty stool, liquid stool, bowel urgency, all these symptoms sound a little bit like IBD, so it's like piecing it apart. So if you see like, oh, I have low inflammatory markers, but I'm still having urgent, frequent loose stool and I don't know why. Like, is there anything else going on with the liver? Is there something going on with bile acid malabsorption or this pancreas insufficiency that could create those symptoms? Another one for this condition is feeling full quickly. So same with a condition like SIBO, you eat a couple of bites and you feel full. And you definitely did not have enough food to make you feel that full. It's basically food arriving that can't be broken down. And so then your body is like, nope, I can't do this. So you feel full with even just a little bit of food. Okay. And the test for this one is a random stool test, not a 72-hour. So pancreatic elastase is what's measured. If it's less than 100, that's severe. And then the treatment for this being deficient is replacing it with pancreatic enzymes. So sometimes I'll see somebody with liquid stool. We do this test. We see low pancreatic elastase. We replace with pancreatic enzymes, and they might make formed stool. So it can be that much of a difference. And there are over-the-counter and pharmaceutical versions. So this is my last slide, I swear. So short bowel syndrome, if anybody has had a small intestine resection, then short bowel syndrome is when you have less than 180 to 200 centimeters of your small bowel remaining. And so then this basically requires that you're going to need nutritional replacement and fluid replacement, maybe some supplements, if there's this little of your small intestine remaining. Then you might need IV nutrition or intramuscular nutrition, instead of just expecting that if you eat more of something or you take supplements, that you would be able to absorb them. You might not be able to absorb them if you're missing those pieces of the small intestine. So yes, the colon can start to adapt to some things, but some of these things are pretty specific to the small intestine. And so when people have, short bowel syndrome, it's like you were just given SIBO automatically, because the colon bacteria are suddenly in a place that is normally associated with the small intestine. And so that's basically what SIBO is like bugs that might be normal for the colon existing in the wrong place. Exocrine pancreatic insufficiency and bile acid diarrhea would be present because you're not reabsorbing those bile acids, and then also there's rapid transit of the food and stool. All right, I know that was a lot, and I apologize, and I thank you so much for your attention. I don't know how not to be thorough, so thank you so much.
All right.
Questions?
That was fantastic. Thanks for a deep and comprehensive rundown.
Oh, thanks.
I'm sure I'm going to get questions here. Thank you. Bring them on up.
I know, like after lunch. Oh, I forgot to put I have Facebook and Instagram as Dr. Christine Bowen. I'm like, that's it.
Thank you.
Like, apparently I didn't get that right.
So as you guys write the questions and think through what all this means, I want to tee this up, because the reason we asked Dr. Bowen to give this talk was because it opens up the conversation to two pretty big areas that I've always grappled with and want to explore with everybody here. One is when I imagine everybody here or family members are diagnosed with IBD, whether it's Crohn's or some form of IBD, you see it kind of goes in our medical records, right? And it's sort of stamped on our medical history, right? And then over time, situations may come up. You may, find yourself in the emergency room or finding a new doctor with some issues. And the first thing they'll look at is your diagnosis. And there it is, IBD, Crohn's, whatever. And whatever you're dealing with at the moment, at that time, whether it's cramping or bloating or diarrhea or any number of things that might come up, a lot of times the doctors will immediately attribute IBD as the source of the problem, because you've kind of already been kind of stamped with that diagnosis, right? And then they'll start treating you with even more intense IBD medications. They're like, maybe your biologic isn't working, we're gonna double it up or something like that, which is sort of understandable if they're gonna think that way, but it's not really leaving a lot on the table. They are really not going through the list of ideas. If somebody else came to the same situation, did not have IBD diagnosis, they will go through a workup. They will go through a lot more exploration. They will look under the hood and try to figure out what the heck's going on. And maybe IBD is the last thing they're gonna think about, right? Not the first thing. So that's caused a lot of trouble. And I think in case the situation comes up where you find yourself in a tough spot, where maybe your IBD's been in a pretty good place, actually. You've been in a pretty stable remission, but something just pops up out of nowhere. And I don't know, you see a new doctor or find yourself in the emergency room. Don't let the diagnosis run the show, right? Don't let them start treating you for IBD right off the bat. So I would challenge anybody at that spot to say, hey, my IBD's been in a pretty good remission. I've been stable. This feels a little different. So challenge them. Don't ignore it, but ask a few questions.
Like, could you go back to the drawing board and start from fresh to make sure we didn't miss anything previous? So that's something that I would encourage people to do, is try to get the workup done again. It's like start from beginning. Hey, did you rule out all of these other things? Did you know that I had a family history of celiac disease? Can we talk about that?
Yeah, and almost ask them, hey, what would you do if I didn't have IBD on my paperwork? Right? So that's one important thing. The other important thing relative to the people we have here in attendance is on SCD. So this has happened to me more than a few times, is I've been supporting patients with SCD. They've been compliant, dedicated, doing it for a while, making really good progress, and then something goes south, right? Intense gas or bloating or diarrhea comes back or something goes wrong, and they get all worried that their IBD's getting out of control. They're coming out of a remission state, maybe starting off a flare, and they get all nervous and maybe start doubting SCD or doubting all the things they've been doing all along and wondering if they're sliding into a sort of a negative remission state of IBD. And it's worrisome, right? And my talk back to them is, hold on a second, let's pause. You're doing SCD really well. I'm not seeing anything to worry about here, and you've been in a pretty stable place. Let's not automatically assume that you're sliding into an IBD flare, right? Let's not automatically assume your SCD isn't working for you, right? Hit pause. Let's go through everything Dr. Bowen just talked about. Let's make sure this is not more of a SIBO acting up and showing up as pretending to be IBD, right? Or is it something else? So these are going to be overlapping symptoms, and in your head, they may sound like IBD or feel like IBD and cause concern, maybe make you doubt what you're doing is right, maybe cause a adjustment of your whole routine, but it may not be necessary. All right, so I would say really dig in and explore some of these secondary causes. Of course, you can have overlapping conditions of true IBD, like actually inflammatory, active state of disease with IBD, while also having SIBO, while also having IBS, right? They can overlap at the same time, but I think you have to dig deeper and make sure it may just be that you've done such a good job on your IBD and it's actually a stable remission state. Give yourself credit for all the things you've done, pat yourself on the back, and then go sort out the IBS matter as a separate issue. It may be that SCD needs to be adjusted, right? So I'm going to get to the questions in a second, but it may be that, hey, you guys know SCD, right? Is garlic SCD compatible? Yeah. But it's not IBS compatible. See where I'm going? So it may be that just following SCD true straight down the middle isn't the right thing. Maybe you actually do have to cut out alliums, garlic, onions, leeks for a while because the actual matter is IBS and not IBD. All right? Same thing with, same thing with like fruits. Mangoes, SCD legal or not? Grapes, honey, but not compatible with IBS or SIBO, actually, right? So those are all fermentable sugars that can exacerbate your SIBO. So it may be that you need to do SCD minus some legal SCD ingredients, right?
Test and treat for SIBO and not limit your diet too much. Because if you're trying to combine diets, you can get painted into a corner that I call food jail. And I want none of you in food jail if we can help it.
Yeah, so you might have to do a little bit of a detour off your kind of true SCD, and this may happen multiple times a year, where you actually dial back all your fruits while you're on SCD, or dial back all your alliums while you're on SCD. Get the symptoms under control. The IBS may go away pretty quickly, or the SIBO may go away pretty quickly, and then you could just jump back in and get back to business, all right? So it requires close monitoring. It requires close sort of awareness of what ingredients you're eating, even though they may all be SCD legal. There might be a little bit of a divergence that you have to do to take care of the immediate matter and then get back on track again, all right? And it may have nothing to do with an inflammatory state in the IBD definition, all right? It may be a functional condition like SIBO, like IBS. All right, so we can talk about that more. I'm sure you want to ask me a lot that. Okay, so I have Crohn's disease and worry about getting MS, multiple sclerosis. What can I do besides SCD to prevent MS? Well, MS being an autoimmune condition.
So you're scared of getting it, is it because it's in your family or just that you have symptoms? Or I guess it would be not, we can keep it anonymous too. So it depends on why you're thinking that MS might be a possibility. And so if it is something like it's in your family or that you feel like you have a genetic predisposition towards it, then things like diversifying your fruits and vegetables is even like one small thing that you can do to help the health of your microbiome. So when we talk about diversity of fruits and vegetables, like if you're always eating Honeycrisp apples, then choose a Cameo or a Gala or a Macintosh or whatever. If you choose 5 different varieties of apples, each of those is going to have a slightly different change to your microbiome. So if you keep on eating, you're nothing but zucchini all the time, then it's like try some summer squash, try something else. So making sure that your foods are not all the same all the time is important for diversifying your microbiome. And then when you get more diversity to your microbiome, you have that healthier microbiome. It's more unshakable than a microbiome that's only got a few species in it. So we really want as broad of a microbiome balance as possible. Also, keeping stress low. I know that that's hard for many, many people, the unavoidable, but that's a major trigger for autoimmune disease. And then I was thinking of one other piece. Getting good sleep would be another thing. Like all of the excellent self-care that you can muster. And then if you're somebody who does use a lot of fragrances or chemicals in your self-care, you might reduce some of those environmental exposures that can be really hard on your immune system as well. So there's a few tips, hopefully, for trying to help your microbiome and keep your immune system healthy and happy.
Very good, very good. Okay, so I have a couple of questions from 2 different people about menopause and how that can possibly send you downwards in any of these autoimmune conditions.
Wow, menopause. So menopause is not a disease, but it can create a lot of symptoms. Yeah, exactly. I'm here to say menopause is not a disease. It is a normal, natural process. Some of us can be more symptomatic than others going through menopause. I recently went through menopause. I'm speaking from very recent experience. But normally when you have menopausal symptoms, it's because your adrenal glands are depleted. And so our whole lives, the adrenal glands are showing up for us, trying to help us, balance out our stress levels. And then when you reach menopause, suddenly the adrenal glands have more responsibilities. And so if they're already depleted from a lifetime of stressors, then by the time you reach menopause, it's going to be hard because those adrenal glands are not going to be able to be there showing up for you. So then we go back to getting good sleep, low stress, not eating a lot of sugar. I don't have to preach into the choir about refined sugar, maybe cutting caffeine. So some of those things can help to reduce the menopausal symptoms because they're helping the adrenal glands. So that's just one thing that you could do. But again, microbiome help as well. And then sometimes people will need herbs or bioidentical hormones to get them through the worst phases of menopause. So something like short-term treatments and then shifting over to adrenal gland treatments, then that could actually help with stabilizing and then getting people into better remission if they feel like the hormone imbalance is part of what upset the system. So a couple of ideas, right?
Yeah, and that's a big subject. I'm sure there's more to
we could do a whole talk
there.
just on hormones and
and also menstrual cycles too, because that's also sort of overlaps with conditions.
Yes.
So, okay, what foods on SCD are generally helpful for liver health?
Ooh, root vegetables. And so carrots would be one, not on SCD. I can think of all of the ones not on SCD at the moment, but carrots or any other root vegetables that are allowed. So any of the Jerusalem artichoke, anything that is a root vegetable that is allowed on SCD. And then also some of the greens like kale and Swiss chard. Those would also be really good liver foods. Not eating toxic foods is great for the liver. But in general, I would say those greens and root vegetables, yeah. Beets, yes, root vegetable on SCD, beets. Beets, carrots, dandelion root, dandelion greens. And then also burdock. Is burdock on SCD? This is probably a way off the beaten path subject. No.
If it's an herb. This is a tough question about liver health because liver does so much. So you got to figure out which part of the liver you're going to try and help. So one of the detox functions of the liver requires an enzyme that requires selenium, and sometimes you're low. And if you can eat Brazil nuts, they're one of the highest selenium containing sources. You can see where I'm going with that. So there's a lot you can do, and then also to take the burden off your liver so that it's not just detoxifying random things,
alcohol,
right?
yeah.
So most people eat way too much sugar and they get fatty liver, and then half the function of the liver is gone. So we don't have to deal with that with SCD, although some people may overdo on fructose. Okay, fructose goes right into the liver and gets sort of stored up in the liver and converted to fat as a storage form of fructose, right? So
more vegetables than fruit is typically what I try to have folks do.
Yeah, for sure. So I don't want you guys to think about like a super heavy fruit-based SCD, right? Not like
fruit and honey, that's it.
fruit and honey is SCD. Again, you can overdo SCD. So if you're eating 6 bananas a day and mangoes and grapes and dates and honey, right? You're doing SCD, but you're not doing your liver a favor. Okay? Because over time, all that fructose will get loaded up in your liver as fat, and then now your liver is struggling to do all its other functions. So I'm not saying it happens. I've never seen it happen, but in a general diet,
grains.
Yeah, in a general diet
Grains
where
and corn syrup.
right, general diet where people are eating high fructose corn syrup, like that's now we're talking a lot of fructose with the sodas and all that. So anyway, just keep that in mind. But there's a lot you can do to maintain a good, healthy liver. Okay, so do you recommend people have separate cooking utensils other than modern cutting boards or rolling sticks?
For celiac, I assume the question is. So for celiac, you really want to avoid cross-contamination. If you can have 100% gluten-free home, that would be ideal. It doesn't end up being possible for some families. So then my patients will have a station that's cordoned off where they have all of their sponge, their own utensils, their own cutting boards, and that they're like, this is my gluten-free zone, but it's really more ideal to have the home be 100% gluten-free for safety. No sharing, I mean, the oven's hard, right? So no sharing the oven technically, no sharing toasters. So yeah, down to even like a lot of appliances different or cleaning them out. And again, easier to have the gluten-free home than that level of like division. How many of us are lucky enough to have 2 stoves? Not me, so.
All right, it's a little bit of a bigger switch topic. So you mentioned low-dose naldosterone, LDN. Naltrexone. Oh, okay.
Yeah.
Yes, LDN. What do you think is the mechanism of action? Do we know?
We do. So back when I started using it in 2007, we didn't know as much. There was like one research study from the 80s, and that was it. And now it is the most well-researched medication in the world. So there's an organization called LDN Research Trust that has a lot of the information. It's free. You can access a bunch of videos and everything about it. And they also can connect you to providers in your area who might be prescribing LDN. And so, yeah, so low-dose naltrexone helps to modulate the immune system. It binds opiate receptors in the brain, which sounds weird, but it binds opiate receptors in the brain, and then it upregulates something called enkephalins. Those enkephalins patrol and correct or balance, modulate the immune system. So it's kind of like a weird trick. The only thing that conflicts with it or is contraindicated are opiate pain meds because they're running for the same receptors. So that could be dangerous if somebody's trying to do both of them. This is not recommended and could be dangerous. But otherwise, it tends to be very well tolerated. It tends to be very safe. If somebody is feeling like they need more heavy-handed approaches, then some of the nutrition or lifestyle changes, and we think that it's appropriate for them, then we might use it. So it's definitely been a tool in one of many tools in my toolbox, but I do love it. And it's hard because if MDs see it, normally they think you're taking naltrexone, which is the full dose medication used for opiate withdrawal and alcohol withdrawal. So they might be like, why the heck are you on this treatment? And you'd be like, It is low-dose naltrexone. It is not naltrexone, and they're very different. So low dose is 1.5 to 4.5 milligrams. The typical big dose is like 50 milligrams. And so the mechanism of why it's used is very different than the mechanism for why the low dose is used. So LDN Research Trust is what I would recommend if you want more information. If you're in remission.
The question was, is there a reason not to take it? Just want to get that audio.
Yeah, so I would say if you don't need it, then you don't need to take it. And so if somebody is in remission and feels like they've solidly been in remission for a while and they don't feel like it's shaky, if you have other autoimmune conditions, then I definitely consider it as one of the treatments. If you feel like nutrition alone can't get you across the finish line, that might be a reason to consider something like that. It has side benefits, unlike some medications. So it can give a general sense of well-being. It can help with sleep. It can help with insulin resistance. So it has some other mechanisms as well, but it may not be for everybody. So talk to your doctor, right? See if LDN is right for you.
Awesome. See if you can read that.
Oh, yeah. No ovaries for estrogen production, so that is a hormone deficiency. So does that affect hormones from cholesterol? So it depends kind of on when the person had their ovaries removed. If it was kind of pre-menopause, then that definitely can shock the system. One of the main hormones that we lose when we have our ovaries removed is progesterone. And so the progesterone being lost is definitely something that can throw the body into like insomnia, hot flashes, lots of other symptoms from no progesterone. But then it does not necessarily have that reverse effect on cholesterol. So you still should be able to make, you still should be able to have cholesterol made in your liver, and that should be fine. But then as far as like how you balance your hormones back out, I don't think that it would affect the liver unless there was a problem with the liver that created more hormone deficiencies. Okay, so that one there would be, maybe working with adrenal or other treatments to balance hormones. If the gallbladder is removed, do I need to add something to my diet to aid digestion if I have no symptoms of an issue? So I guess, if you have no symptoms, some people feel better after their gallbladder is removed. Like they might not have any symptoms, the body might tolerate it fine. Not everybody has bile acid malabsorption from having their gallbladder removed. So if there are no symptoms, you could check for fat-soluble vitamin deficiencies. You could do that stool test to see am I getting fat in my stool, even if I'm not experiencing symptoms from it? Then that might tell you, okay, I'm losing fat. Then that would be a reason to intervene. Typically if there aren't symptoms or labs showing a deficiency or that something is being unaddressed, then if it ain't broke, right? No need to take measures there. Okay.
So I just want to add to that. This is one of my pet peeves. People get gallbladder surgery on a whim in a hospital without too much diligence or time to explore it. And then they're released or discharged from the hospital with no instructions. And 20 years later, they tell me about it. And we do actually have to dig into it. And I do find poor fat-soluble vitamin status, because if you can't absorb fats, you can't absorb fat-soluble vitamins. Vitamin A, vitamin D, hey, that's a big one, E and K. So those are pretty key vitamins, and if you are not able to absorb all your fats because of your gallbladder is gone, you're probably going to be low on those vitamins. And then secondly, weight gain becomes really hard for them. They're just eating a lot and just not gaining any weight, looking 10, 20 pounds underweight, and that's because they're not getting much calories from their fats, right? It's just running out of them. And so I would consider enzymatic support. That's bile and lipase, the two enzymes one's an emulsifier, one's an enzyme that the gallbladder used to provide, and now it doesn't. So yeah, adding those back in definitely helps manage the losses of those fat-soluble vitamins, and sometimes helps quickly gain weight again. So don't.
Yeah, that's a huge thing, is like underweight due to fat malabsorption. Like if you can't absorb your fat, then yeah, that's not going to help with low weight.
Yeah, probably half your calories are coming from fat in your diet. And so if you're losing even 10% of it or 20% of it through poor absorption, for any reason, you're not going to gain weight. So those are things to think about. All right, so look, this is fantastic.
Let me take that should be
Yeah.
fast. Okay. So if someone has advanced cirrhosis because of drinking, if they quit drinking, can the liver heal, or is it too late? It depends on the extent of the damage. And so something like a fibroscan would help. And if the damage is less than 50% of the liver, so it depends on how advanced the advanced is, that they may still be able to recover some function. You know, if it's really advanced, they're probably looking at a liver transplant, if it's, liver failure at that point. But they may be able to recover some function just depending on how advanced the damage is. All right.
All right, fantastic. Look, these are all really good questions. We're really getting into a lot of the key subjects here.
Ideas for
fantastic. We are going to take a, thank you, Dr. Bowen.